So, bona tarda, good afternoon. I'm Dr. Nicolas Manitov from the Advanced Heart Failure Unit and Heart Transplantation from the University Hospital in Barcelona. And my co-chair is Marta Farrero, is the organizer also of this meeting, and she's working on the cardiology unit in the Hospital Clínico Universitario de Santiago de Compostela. The topic of this session, as you know, is distinguished features of the heart failure in women. And we know that the clinical syndrome of heart failure is very common in women. There are differences between heart failure in women and men in terms of epidemiology, pathogenesis, treatment response, and quality of care. So also the clinical trials of heart failure have included fewer women than men, and this has limited our understanding of the efficacy of the heart failure treatment in this group of patients. There are several questions, and I think there is a lot of gaps in evidence on this field. So we have 3 women that are key opinion leaders on this field, just to clarify and to increase our knowledge on this topic. So please, Mila, introduce the first speaker.
Bueno, la primera ponente, que es la doctora Marta Farrero.
Marta Farrero, which is an expert in heart failure working in the Clinical Institute. She's a vice president of the section of the Transplantation and Heart Failure in the International Society of Heart and Lung Transplantation, and she's going to speak us in something that has the heart failure is where there are the special features of gender and where very penalized the natural history of women having this syndrome. The title of Marta is very appropriate, is very pertinent. Women which are unheard, untreated, and unstudied. She's going to analyze this situation.
Being here and for getting me invited. It's amazing to share this day with such an amazing panel, so thanks. Let's start with some numbers. Prevalence of heart failure. This is a study from Catalonia, our area, and by colors you can see easily how men start having heart failure at younger ages, but once you pass the point of 75 years old, you are going to see a lot of blue here. So many women have more heart failure than men, and they are older, which is kind of a starting point for what we are going to talk about. Luckily, heart failure incidence is going down over the years because we are dealing better with risk factors and we have better treatments. This is incidence, and that's important to notice because prevalence is increasing because people are aging and are surviving more. So the numbers of heart failure patients are indeed increasing, although incidence is decreasing. That can be a little messy sometimes, but we'll try to point that out several times. As you see, incidence is decreasing, and it's decreasing more in women than in men, which is also some good news. So we are doing better at diagnosing them and probably at preventing the development of heart failure. As you know, cardiovascular disease is a main cause of hospitalization everywhere. I have data from Spain, and as you see, when we talk about cardiovascular hospitalization, the leading event is heart failure, and that's where women are especially overrepresented. So more than 50% of the heart failure admittances in hospital happen in women. And if you look other diagnoses, other cardiovascular or non-cardiovascular diagnoses, in women, heart failure is 1.4 more frequent than stroke, 2 times more frequent in admittances than breast cancer, and 4 times more frequent than MI. When we talk about mortality, well, you know, heart failure is a deadly disease, and it's more deadly than most of the cancers, right? And if we look at women, it's actually a leading cause of death. It's even more important than in men, you see, by prevalence. Some more good news for us women is that our mortality in heart failure is a little lower than in men. And if you look at this study from the MAGIC study, you see how overall our mortality is lower. And when you look at half-PEF or half-REF, always women are in a better picture here. So some good news for us, finally. But greater improvements over time in mortality are seen more in men than in women. That's because probably most of our efforts in dealing with heart failure are related to half-REF, which is where we are more successful. And as you will see, women are more prone to have half-PEF. So that's probably why we are improving more in men than in women. As we just saw, mortality is decreasing over time. Actually, men and women mortality rates are coming together and are merging over time. In numbers, in absolute numbers, still there's more women dying than men dying. You see it's almost twice as many women as men dying for heart failure. But when you see here women being in red, they are an average of 5 years older than men when they die. So, good and bad news. What are the risk factors for heart failure? We share a lot of risk factors with men. It's just that they don't affect us the same way. So as you see, hypertension, diabetes, ischemic heart disease, smoking are common risk factors. We will be repeating that ischemia is not so important in heart failure in women, but I just want you to remind you that once a woman has an MI, she is much more likely to develop heart failure than when a man has an MI, although we don't have that many ischemic events. So there are also some conditions associated with heart failure that have different prevalences between the sexes and also risk factors. So when you look at the women's spectrum over time, you see that there's an increase. Our likelihood of having heart failure throughout the years is about 20%, which is a rate that's quite similar to the one that men have, just they die earlier on, so numbers are not that big if you look at the general population. But we have some specificities, and those are related in younger ages with peripartum myocardiopathy. And in older ages, we also have, like for example, Takotsubo cardiomyopathy, which is much more prevalent in women. HFpEF, that we are going to talk about a little bit more, it's much more prevalent in women. And also the strength of these risk factors in women is bigger than it is in men. If you look at this registry, we see how the traditional risk factors are the same, but most of them are much more significant in women. So for example, as we just heard, if you are a diabetic, you have higher chances of developing heart failure if you are a woman than if you are a man, and the same thing happens with hypertension. If we look at a specific etiology, such as alcoholic cardiomyopathy, we know that alcohol consumption is higher in men, but it affects more the women's heart. So even if it's a lower prevalence of alcohol disease, its incidence of heart failure is important too. Same thing happens with cardiac sarcoid or amyloid, which have usually worse prognosis in women. And also all these conditions, I would like to point out that anemia, which is a very important conditioning of performance, and it's really related to heart failure, it's much more common in women too. So if we look at the whole picture here of ejection fraction and sex and ages, you see how most of the men in heart failure have lower ejection fraction, whilst if you are going to the normal-ish ejection fraction numbers, then women become really important. Why is that? Well, you know, HFpEF is much more frequent in women. It's been said that it's twice as prevalent than in men, and that's related to many factors. Most of them are not really well studied or not well known, but there's a genetic influence. There's also some issues related to size, to hormone inputs, to inflammation, and all these clustering risk factors as metabolic syndrome. So we have a different myocardial structure. We have smaller hearts. Even if you standardize that by our body weight, our hearts are a little smaller. So cavities are smaller, and we tend to compensate that with higher heart rates. So a woman's heart is a woman's cardiac output, let's say, is much more dependent on heart rate than it is for men. Also, over time, our heart tends to adjust to all these risk factors with hypertrophy, much more than with dilatation, which is what happens with men. We have a different cardiac metabolism. We are a little less efficient, and we are much more prone on working on lipid profiles, and we are not that good at using ketone bodies or other kind of energy sources, and that allows us to remodel our hearts in a different way. And also vascular dysfunction. I know you've already talked about pulmonary hypertension, but it's not only related to that. It's also related to ventricular arterial coupling. It's also related to the increase in angiotensin that happens more frequently in women. So all those risk factors added to our characteristics make that women are much more prone to have HFpEF than HFrEF. What happens when we look at hospitalizations for heart failure? So as you look at this registry, it has a similar proportion of women and men, which is good news for once in registries and studies. So as you see, as we just said, women are older, they have less ischemic heart disease and more hypertensive, and their ejection fractions are usually higher. They also are more comorbid, as you see. The only thing we are better at is at having less renal failure. So we still have some good news for you. And if you look at how they were studied when they were admitted, they underwent many diagnostic studies. So they had less exercise stress tests, less echocardiographies, less Holters. So it looks like women don't deserve that many studies. And if you look at the treatment they were discharged on, not only in hospital, but at discharge, which is probably even more important, they were prescribed less ACE inhibitors and less spironolactone, and we received more digoxin, which is something we could discuss if we like that or not. So in other registries, those differences were not seen, but there is, in fact, differences in other registries in anticoagulation rates for women that needed that anticoagulation on CRT and ICD, and that's important and quite surprising on heart failure education, so, which is nothing related to side effects or other courses that we could argue. So I know you've already talked about this, but it was quite striking to me to see how we are not receiving CRTs when in fact we are the ones that are the better responders to them. So something really we should think about. So why do you think this is happening? And I made these 4 points that we'll try to elaborate on a little bit more. First one is awareness. I read a Swedish study that was quite interesting on trying to see how women or men are represented in advertisements, like in general TV shows talking about heart disease. And this is the profile of men, of a patient that has heart failure or has heart disease. So women in the population were represented only as fatty women having lipid problems. That was kind of the cluster for women, whereas all other cardiovascular problems were related to men. And I did this exercise this morning, and I Googled heart failure patient, and like 90% of the pictures that I got were men. So, and this is actually the first one I got. So we need to be aware, and as physicians, I think that social input also affects our practice. We need to be aware that women can have cardiovascular disease. Another thing is symptom identification, and many studies have shown that we are quite bad at expressing our symptoms, and we may have atypical symptoms. And physicians need to be aware of that, and we need to understand that some symptoms may be related to heart failure or decompensation in females. In that sense, I wanted to point out this device. This is a CardioMEMS. This is a device that you can implant in the pulmonary artery, and that records your pulmonary pressures over time. This device has been shown to decrease heart failure admittances about 50% in patients with recurring heart failure, and that's just because you can detect rises in pulmonary pressure and then treat the patient beforehand. So this device was especially interesting in women. In women, the reduction in heart failure admissions was about 60%. So that's dramatic, and that's probably because you don't have to interpret symptoms with this, right? You just see pulmonary pressure and treat the patient. So we need to find skills and find ways to identify symptoms better for women. And then there's lack of knowledge, and actually we really don't know if these drugs work or not in women. All we have is subgroup analysis, which you know that statistically are not very reliable. This is a study looking at different cardiovascular drugs in trials, and as Dr. Juanate was saying, we need to look at the percentage of the prevalence of the disease in the population and see the percentage of women in those studies. That gives you a number. If it's below 1, it means that women are underrepresented. So if you look at the different topics where we could study, heart failure actually is one of the diseases in where women are less represented. It's about 24% of women in our in our trials. They are mostly overrepresented in pulmonary hypertension, which is something that we all know that it's a woman thing, right? So we overrepresent them there, and then we go down on other trials. Now looking at heart failure trials, and I wanted to have this mice here to remind myself to tell you that I just found out that in basic science they also use male animals, and if they use female animals, they don't look at their hormone status at the time of the study. So even rats have gender or sex discrimination, right? So female rats. So if we look at the studies in heart failure, look at how many of them have such a low rate of female inclusion. It looks like we are doing better lately. If you look at COAPT, it's 33, and if we look at Paragon, it's 52. Wow, that's good news. Is that really good news? Like, you know, this is HFpEF, when we just said that women have they are two times more women with HFpEF than men. So still not very good news, even if we have that 50% there. Even in registries, I was quite surprised to see this registry in which you see that females are underrepresented, even in registries, which doesn't make much sense, right? Also, it's hard for us to put women with heart failure on some drugs because adverse events are more frequent. It's 1.5 more times to have adverse reactions. And we really don't know much about it because only 7% of the studies report adverse reactions and sex. So it's hard to know exactly how these drugs affect women and men in a different way. But what we know is that cough and angioedema are more frequent in women with ACE inhibitors, and we have to be really aware about their teratogenesis in younger women. Some studies have shown them that women are able to get to the same target doses. Regarding beta blockers, we can have higher plasma levels, so we need to be aware that the bradycardia can be more frequent, although in most of the studies, target doses are the same for men and female. And digoxin, you remember I just told you that we are prescribed digoxin more frequently than men? Well, it kills us more. So women are prone to have side effects of digoxin, especially arrhythmic events. And that's probably because we have higher doses, higher circulating doses with the same, like levels with the same dose. And we have less benefit from it. So from the big trial, actually, women had less reduction in rehospitalization. Some good news to give you. We have less withdrawal with mineralocorticoid antagonist. That's probably because of the hormonal effects it has in men. They don't like having boobies, and we kind of not notice that. So why do we have all those adverse events? It's probably because we are not small men, we are different, and there are some differences in our metabolism that makes that all those drugs are not designed for us. So we have a higher percentage of body fat, sorry for that, and that makes us have higher levels of hydrophilic drugs. So when you take a drug that's hydrophilic, that gets at, and our distribution volume is lower, so it gets high on us. Whilst if you have a lipid profile drug, it tends to be accumulated, so it can have longer effects. Also, we have smaller kidneys, which do not help too much in filtration. We are more prone to arrhythmias, and actually women are, they have 2/3 of all the dorsal points are drug-induced. So we have to be really aware of this electrolytemia in women, and also liver metabolism and all the enzymes their function is related to hormone status, so drugs can change over time. Also, women have, as I told you, are older when they get heart failure, then they have more comorbidities, and they also have some more issues with compliance. So all that picture makes drugs to be difficult in women. And let me just give you a hint of advanced therapies in heart failure, because that's what I'm really passionate about. I wanted to talk to you about LVADs and women. When we started with LVADs, that was really hard to have an LVAD on a woman because those were big and surgeries were much more difficult in smaller bodies. Now we have changed. We have really small devices, but still 80% of the VADs are put on men. We just have a slightly higher risk of stroke. That has not been seen in HeartMate 3, which is our latest device. But I have to tell you that we only had 31 women to report, so it's kind of difficult to know if they actually have more or less stroke. But what's nice to see is that even with older LVADs, or even with the newer ones, results are good enough. Like, we have the same good results with LVADs, so we should really move towards that. And then when we look at heart transplantation, again, only 25% of the heart transplants are performed in women. That it's quite reasonable, because we get heart failure when we are older, but that's probably not only the only reason. So pre-transplant, women are younger when we are enlisted. They have different etiologies. So as I told you, ischemic heart disease is much less common. They use less circulatory support, even short-term support. And they have a higher mortality while waiting on circulatory support than men. We have problems with sensitization. That's something that transplant cardiologists are very concerned of, that is related to circulating antibodies that we have against other people that could be potential donors, and we get that by pregnancies most of the time. So that's kind of unique to women, not unique, but very special. And wait-list time for women is usually a bit longer, probably related to those sensitized and having to wait until a suitable donor comes. Then outcomes in women, good news, is that are better. So we tend to live longer with a transplant year. longer, and that's related probably to a less frequent incidence of vasculopathy and malignancy, although we have more antibody-mediated rejection, which is related to those antibodies I was telling you about. And there are some specificities that we need to think of when we have a young heart transplanted woman, and it's that they may need or may want to become pregnant, which is a challenge for us, but we should not stop them if we should advise them not to, but if they really want to, we have to be by their side and try to manage transplant. And also about side effects, because, for example, cyclosporine, which was the most common immunosuppressive drug, has his hirsutism. So all these women have a lot of hair all over, which is, again, so we need to be aware of special side effects. And only something I wanted to tell you about sex matching in heart transplant. As you see, most of the donors and most of the recipients are men everywhere in Europe and in the States. But we need to pair them properly. So if you put a female heart in a male recipient, he's not going to do well, right? So it's kind of a little revenge over time. So the best pair would be female-female. We get along very well. And then a male-to-male would be another good pair, but usually not female-to-male. So overall, what I wanted to tell you about heart failure in women is that we are usually older. We have a higher prevalence of comorbidities such as hypertension and diabetes. We have more HFpEF. We have less ischemic cardiomyopathy related to heart failure. And we are less treated and less diagnosed than men. We get transplants rarely, and we have a higher risk of stroke with LVADs. But overall, our prognosis in heart failure is better. So with that, I'm going to close and thank you.
Thank you very much. Thank you very much.